all we will see is a T wave. So between an RRR, there is a T wave. So we have a regular narrow complex tachycardia. What is the differential diagnosis of a regular narrow complex tachycardia? The most important cause of a narrow regular tachycardia is supraventricular tachycardia, or AVNRT, or atrioventricular nodal reentrant tachycardia, which represent 80% of the cases of SVT. So this is an SVT. How we manage SVT? Remember, we don't need to give adenosine to all patients coming with SVT in the emergency department. Sometimes they respond to Valsalva maneuver. And there is a tweet that I have posted before about how you treat a patient with reversed Valsalva maneuver. You raise the arms, you raise the legs upside down, and you ask the patient to breathe against a closed mouth. So this is the way you treat sometimes SVT non-pharmacologically. You can also sweep on the carotid artery one by one, not together at the same time. This is contraindicated. If the patient did not respond to non-pharmacological management, then you might administer adenosine. Adenosine have a short half-life and it should be given within a large cannula or a large IV line. SVT start suddenly and stop suddenly, and very, very rarely the SVT will cause any harm. Sometimes SVT can be a sign of myocardial ischemia in elderly people. So if somebody who is 60 or 70 years presented to the emergency department with SVT, you need to consider myocardial ischemia as a probable precipitant for his SVT. And remember, SVT is usually associated with good prognosis. The management, if the patient is having recurrent SVT, is by electrophysiology ablation, as you ask the electrophysiology consultant to do the procedure. SVT can be treated by adenosine or by verapamil. Adenosine is contraindicated in patients with asthma or patients with prior transplant. So this is the example we finished. So let us take this example of another ECG with a very coarse ECG. You look to lead 2, as we told you, and you look to V1, you will find that there are abnormal waveform between the RR and the RR are not regular. So this is either an atrial fibrillation or atrial flutter. It is more towards atrial flutter because if you look to V1, it has the shape of a saw-tooth appearance. So this is atrial flutter. In the USMLE or other exams, I might ask you, where is the circuit of the atrial flutter has originated? It is originating from the right atrium, sometimes around the tricuspid valve isthmus. So this is the site of the atrial flutter. Atrial flutter treatment is by anticoagulation, heart rate control, but the most important intervention nowadays by electrophysiology ablation. Patients with atrial flutter, they have risk of stroke or systemic embolization, and they should be anticoagulated if their CAT-VASC score is more or equal to 2 in males, or equal or more than 3 for a female for the CAT-VASC score. So this is an atrial flutter with variable block. The patient deserves anticoagulation, and electrophysiology study and ablation of the right atrium circuit is the treatment nowadays. So what about this ECG, which has like a broad complex tachycardia at the beginning? So this is a 50-year-old male with a prior MI and coronary artery disease, and he is at risk for serious ventricular arrhythmia. So this is like ventricular tachycardia because it is wide, complex, regular tachycardia. And we can see that there are normal beat, which is called capture beat. After the ending of the ventricular tachycardia, there is one beat. This beat, we consider it as normal beat. If you go to the other beat, this beat is a fusion of an abnormal beat and a normal beat. We call it fusion beat. The presence of a normal beat and a fusion beat makes the diagnosis of ventricular tachycardia easier. And in a patient who had a prior history of an MI or a scar or a history of coronary artery disease, is likely to suffer from ventricular tachycardia. And this is a patient you need to consider him for an ICD unless he came with a fresh MI. If a patient with ventricular tachycardia came with fresh or acute MI, you treat the MI, you don't give him a defibrillator. But if he comes without a history of a recent MI, he might tell you that the MI history is 10 years or 1 year or 5 years, and he comes with ventricular tachycardia, then he deserves an ICD or a cardiac defibrillator. What about this ECG? You can appreciate that this ECG has a wide complex QRS complexes, and at the beginning of the QRS, there is a notch or there is a spike. So this is a pacemaker spike. So this is a based rhythm, and it indicates that this ECG gives you also further information that the patient is dependent on the pacemaker, and that the pacemaker is working normally, because with each QRS, there is a pacemaker notch or a pacemaker spike. So this is a based rhythm. What about this ECG with a patient who had an anterior STEMI? If you look to V2 and V3, you will find that there is ST elevation in V2, V3, V4, V5, and V6. And there is the QRS is more than 110 millisecond. We call it an intraventricular conduction defect delay. So this is a patient with anterior STEMI, and he has a recent or acute anterior STEMI. He is in normal sinus rhythm because there is a B wave before each QRS complex. So what about this chest X-ray for a patient who had presented with anterior STEMI? This is easily, these days you might consider a patient who is COVID pneumonia, but in a cardiac situation, this is a patient with acute pulmonary edema with bilateral hilar shadows and bilateral fluffy shadows, more on the lower basis of the lung, more than the upper basis of the lung. Acute pulmonary edema or cardiogenic or heart failure is the most common cause of complication of acute MI. This patient underwent primary PCI, and there is an artifact here. This is an intra-aortic balloon pump. So this is an intra-aortic balloon pump for this patient who is hemodynamically unstable with acute pulmonary edema, bilateral hilar shadows, and bilateral fluffy shadows of Pat's wing pulmonary edema. So what about this patient who had a recent MI and he came with severe chest pain? you find that there is ST elevation in lead 3, AVF, and there is significant ST depression in V2, V3, which is the posterior component of the MI. So this is a patient who came with a recent infra-posterior MI, but still he is in normal sinus rhythm. Sorry. What about this ECG? This is a 60-year-old male who having a rhythm disorder, and he presented to the ER with severe chest pain. So severe chest pain, you need to consider acute MI, acute aortic dissection, massive pulmonary embolism, tension pneumothorax. So the patient is hypertensive because the voltage criteria for the R and S are elevated, but the patient is having no B wave. We don't find any B wave. If we look to lead 2 and we look to V1, we don't have any B wave, and the RR interval is not regular. So this is a hypertensive heart patient who is in atrial fibrillation. He presented now with severe chest pain. We should do the ECG within 10 minutes. And when we did the ECG, you can appreciate that there is ST elevation in V2, V3, V4, and V5, and the T wave are peaked. So the patient presented acutely, or he presented early with acute anterior STEMI, and this is a patient who need to go to the cath lab to get his primary PCI within 60 minutes from recording of this ECG, or less than 90 minutes from reaching the door of the emergency department. So this is the waveform and intervals. We have an isoelectrical baseline before the B wave. We have a B wave, then we have a QRS complex. And remember, the Q wave should not be more than 1 millimeters, or should not exceed more than 1 small square. Otherwise, this is pathological. The T wave represents ventricular repolarization. If there is a U waves, then we expect it to appear after the T wave. Let us take an example about short rhythm strip, and we will ask you about the heart rate and rhythm. So this is a patient who is a little bit brady, and we need to calculate the heart rate. If the RR interval is regular, then it is easy by 300 over the number of square between the RR and the rhythm of the patient, because there is a B wave before each QRS complexes, then it is a sinus bradycardia, and it is 300 over 6 squares between the RR interval give us a heart rate of 50 beats per minute. The normal heart rate is 60. The normal heart rate is between 60 to 100. If it is less than 60, we call it bradycardia. If it is more than 100, we call it tachycardia or sinus tachycardia. So let us take another example of this is rhythm strip and the heart rate. It seems that the RR interval is regular, so we can apply our formula of 300 over the number of square, which are 4. But the patient has a sawtooth appearance on the ECG waveform, and this is consistent with atrial flutter. So the patient is in atrial flutter, but with a fixed block. If we divide 300 over the number of squares, we will find that the ventricular rate is 75 beats per minute. What about the rhythm and heart rate here? This is a white complex tachycardia, and the squares are 1.5 squared. So if we divide 300 over 1.5, we will get 200. and 200 is usually the rate of ventricular tachycardia we encounter in most of the cases. So this is the way we can calculate the heart rate when we have a fixed or a normal RR interval. What we should do if we don't have a normal or a regular RR interval. Let us take this example, and maybe this might be the final example we can take. This is a bizarre ECG. You can appreciate the patient is tachycardic. It is irregular, and the QRS is wide enough. It could be ventricular tachycardia, or it could be aberrancy, or it could be WBW with atrial fibrillation. How we can calculate the heart rate? We need to count the number of RR in the whole ECG, and then we will multiply by 6. Remember, the ECG we record take 10 seconds to be recorded. If we would like to calculate the heart rate, we calculate the number of R's, and then we multiply by 6, and this will give us the heart rate here. So this will give us a heart rate of 198 beats per minute. And this is a patient who has WBW, and he came to the ER with atrial fibrillation. This is a patient who will be treated with procainamide. He will not be treated with calcium channel blockers because they are contraindicated. He will not be treated with amiodarone. In the past, they were given amiodarone. Now, amiodarone and calcium channel blockers are contraindicated for these type of patients, WBW, because they can increase the risk of ventricular arrhythmia, and this is a granted USMLE question. Thank you very much. وآخر دعوانا أن الحمد لله رب العالمين. If you need the slides, I can send it to everybody. This is my information. You can reach me in my Gmail account or in my mobile. And I could also upload. I think I missed the recording. I recorded the second half of the lecture, not from the beginning, but I could record it and upload it on YouTube. Thank you very much. And maybe in the next coming few days, we can organize another meeting, Zoom, about chest X-ray interpretation. Thank you very much. Jazakum Allah kul khair, and have a nice night or good night. And take care and keep well, you and your families and friends. Thank you very much.